Good afternoon. I'm Mike Siatkowski. I'm a pediatric and neuro-ophthalmologist in Oklahoma City, and I also serve as a senior ophthalmologist for our ROP service. I'm the chair of the Department of Ophthalmology at OU and also the CEO of the D. McGee Eye Institute. I'm very honored to present this ROP update at this meeting on behalf of the Ophthalmic Mutual Insurance Company. Through the course of this talk, we'll review closed claims over the past decade for OMIC and look at different important learning points from each. I'll conclude with a few remarks on informed consent and patient interaction as well. I do need to disclose that I am a committee member for OMIC, for which I do receive compensation. I also receive research funding from the National Eye Institute, as well as compensation from the American Academy of Ophthalmology for an associate secretary for program position. Neither of these two is related to the content of this talk. I'd like to start out by looking at the largest settlements of all time over the history of OMIC. OMIC was formed just over 35 years ago. And the first thing you will see is that the number 1 and 2 payouts in the history of the company deal with failure to diagnose and to treat ROP. Those two alone comprise about $5.5 million. In the top 10 is another ROP case that paid out at $1.5 million, and rounding out the top 20 are 2 more $1 million cases, again with failure to diagnose or treat ROP. So in the top 20 cases for payout in the history of OMIC, you see that ROP payouts comprise almost $10 million, or 36% of those paid claims for the top 20 cases. So obviously, the stakes are enormous, and the importance of getting ROP right is huge, not only for our patients, but for us as physicians as well. We'll start to review some of the closed cases now. The first case starts with a 31.5-week baby born with a birth weight of 1,543 grams on February the 22nd. The baby was not examined for ROP in the hospital, but was discharged on March the 17th. In the discharge summary, the neonatologist states that, quote, baby is at risk for ROP, obtained screening exam at 4 weeks as outpatient. A request for an exam was faxed to the office of the insured ophthalmologist, but on this request, there was no mention of the fact that it was to be an ROP exam or that the baby was felt to be at risk for ROP. The mother contacted the ophthalmologist's office for an appointment, and the response of the office was that you don't need to be seen now since you were not seen as an inpatient, so it's appropriate to follow up at our next opening, which would be in April. The mother called the pediatrician back, who recommended that she get the soonest appointment that she could, and I think that was the conclusion of the conversation. So accordingly, on April 29th, the baby was examined and found by the insured ophthalmologist to have macular ectopia in the right eye and a stage 4B detachment in the left eye, and went on to vitrectomy. The final outcome of this patient was 20/60 in the right eye and no light perception in the left eye. From a legal standpoint, counsel considered the following things with respect to this case. The first thing I came up with, when should an exam be performed? Is it under 32 weeks or is it under 30 weeks? And obviously we all know that there's been a change in the national recommendations in this regard. But for this case, it really doesn't matter, because whatever the recommendations were at that time, the neonatologist felt that the baby was at risk and needed an exam. So therefore, the neonatologist's interpretation of the case overrides the national guidelines. Although the neonatologist felt an exam was needed, for some reason the hospital ROP coordinator, who was hired by the hospital, and they did have a safety net in place, but the ROP coordinator was not involved in this case and therefore did not make an appointment. Nor did the neonatologist make an outpatient appointment before discharge. Now, it's certainly true that a baby of this age and this birth weight is a relatively low risk statistically for severe ROP. Nevertheless, again, the neonatologist felt an exam was necessary. The ophthalmologist's office did not understand or have information that the evaluation was to be for ROP. They did not get the discharge records from the hospital directly, only the request for an evaluation. There's no question that the care of the insured ophthalmologist was completely appropriate. As soon as he saw the patient, there was a referral made to the retina specialist for appropriate surgery. Unfortunately, the child was very visually impaired, and overall, taking into account these factors, the lawyers estimated that the verdict, chance of a verdict on behalf of the plaintiff was approximately 60%. So some learning points here. Again, the baby didn't get an exam in the hospital. Now, this baby was only 5 days away from when the exam was intended. So certainly the ROP coordinator, the neonatologist, should have considered an early exam. It's particularly important to have the baby seen in the hospital and get into the system so that the tracking system can take place on behalf of this baby and prevent problems with follow-up. So unfortunately, this didn't occur here for reasons that were not clear. The second issue was the clarity of communication from the inpatient to outpatient transfer in when the appointment should occur. So if an exam for ROP is recommended, again, the hospital ROP coordinator should be scheduling this. But at any rate, the communication has to be very clear. Any communication with physicians, especially in the difficult transfer point from inpatient to outpatient, has to be extremely clear. The way the referral was warranted, the office staff interpreted it to be 4 weeks after discharge, when the neonatologist really meant it 4 weeks after birth, which would have just been 5 days after discharge. So thus, it's really important that everybody use specific dates, or at least a clear window of a date range when we're discussing timing of next appointment. And again, just so we remember the current AAO, AAP, APOS guidelines, based on gestational age at birth, a baby who is 31 weeks, as this baby was, should be seen 4 weeks later at 35 weeks. And they were discharged 3.5 weeks after birth, so they should have been seen within that first week after discharge. Unfortunately, they went about 5 weeks after discharge because of the unclear wording in the referral. So this is something we have to be really tight on. The final thing to remember through this case is that we all understand this is a low-risk baby statistically, but low risk does not mean no risk. And regardless of the birth weight or the gestational age of birth, once the neonatologist decides that a baby has a high enough risk to be examined in ROP, even if they don't meet the guidelines, that means the neonatologist has thought that the baby's clinical course is unusual or unstable enough so that ROP is a risk, and we as ophthalmologists have to treat them with the same level of heightened concern that we would treat a 25-week, 800-gram birthday baby. So the outcome of this case was, after mediation, the insured settled for $75,000. OMIC paid for this, and another $375,000 on behalf of the hospital came from a state compensation fund. The second closed claim of the last decade goes back to the year 2005, and you'll see why this is important. On August the 10th, the baby was born at just over 25 weeks with a birth weight of 635 grams. The first exam in the hospital was done by a doctor who was not insured by OMIC and was not in the practice of the regularly covered doctor. So the OMIC insured first saw the baby on October the 6th, noted zone 2, stage 1 in each eye with no plus, and recommended a follow-up in 2 weeks. 2 weeks later, baby was noted to have zone 2, stage 2 in the right eye, zone 2, stage 1 in the left eye, again with no plus. A follow-up was recommended in 1 week this time. A week later, zone 2, stage 2 in each eye with mild plus. Follow-up is recommended in 1 week. On November the 2nd, exam is listed as no change from prior. Follow-up again in 1 week. November 10th, zone 2, stage 3 for 1 hour in the right eye, zone 2, stage 2 in the left eye with mild plus. Follow-up in 4 days, noted to have improved plus. Follow-up in 1 week, noted to have decreased neo with less plus in both eyes, recommended follow-up in 1 week again. November 28th, no plus either eye, 1 clock hour of stage 3 in one eye, follow-up 1 week, less neo in the right eye, none in the left eye, 1 week follow-up, no neo either eye, retina flat in each eye. Follow-up was recommended in a week. However, before that week occurred, the baby became unstable medically and was discharged from the hospital and transferred. So at that point, the baby was seen by a different ophthalmologist who found a stage 4A detachment in the right eye, 4B detachment in the left eye, underwent laser and vitrectomy and scleral buckling, and finally ended up at 2200 in the right eye and no light perception in the left eye. So some considerations here for this case. The 2005 is important because this case occurred shortly after the national standard of care changed from the cryo-ROP study to the early treatment for ROP study. And you'll recall, of course, that in cryo, plus disease was required for treatment along with stage 3 of at least 5 contiguous clock hours or 8 non-contiguous clock hours. Whereas in the ETROP study, it's really the presence or absence of plus was the driving factor for treatment decisions. So if you look back at the follow-up from this patient, so today, of course, this patient would be treated here on October 26, but under the cryo-ROP guidelines, follow-up in 1 week would be appropriate. Okay, so again, compared to cryo-ROP, this insured totally met standard of care, but did not meet the standard of care under the ET-ROP study. And of course, the other factor is that according to the insured's notes, the exam showed improvement through discharge time. You can see at discharge, retina flat, no neo in either eye, but a week later, obviously, detachments bilaterally. So overall, the lawyers estimated another 60% chance that the verdict would be on behalf of the plaintiff. And we'll talk a little bit more about some of these points in more detail. So the first thing is, when we're describing plus disease now, again, the key is it's either yes or no. It's a binary phenomenon. It's present or absence. As per ETROP, its presence, not the extent or severity, is what tells us when to treat. So mild plus, bad plus, worse plus, better plus is not really important. It's either plus or it's not plus, and if it's plus, now we need to be thinking about treatment. The next thing is sustained improvement followed by quick significant worsening invites questions about accuracy of exams. Again, we showed you how the exam findings improved over the course of the hospitalization. At the last exam in the hospital, there was known to be no neo, no elevation of the retina in either eye, but yet a week later, there are bilateral detachments. So something that dramatic, that fast, raises concern about the accuracy of not just the immediate prior exam, but all of the examinations that the doctor performed in the hospital. So that's not helpful, although certainly it can be possible, but would be unusual. So there's a big question mark about accuracy that comes up then. And the last thing is we need to recognize that physicians as a group, we are often very, very slow in adopting new standard of care practice patterns. So just as an example, the optic neuritis treatment trial was published in 1992. And in this trial, it was recommended that patients receive IV steroids followed by oral corticosteroids as treatment for optic neuritis, because if they got oral steroids alone, they were at a higher risk of developing multiple sclerosis than if they received the IV steroids first. Unbelievably, 20 years later, a survey of ophthalmologists showed that there were still about a third of ophthalmologists treating optic neuritis with oral steroids alone, and over 50% of neurologists were treating optic neuritis with oral steroids alone. So 2 decades, the penetration of the practice pattern change still hadn't done very well. So granted, we're talking about a smaller time window in this case. Now, to remind you, the ETROP study was stopped suddenly in the fall of 2003. And as a PI for that study, I remember getting the emergency call to attend some findings in Chicago on a weekend. I think it was in October. And it was clear that early treatment gave a better outcome. So the first major publication from the ETRP group occurred in early 2004. So this case was in 2005, about a year and a half after that 2004 publication. So clearly in those, that year and a half, the insured should have adopted the new practice patterns, especially in a disease like RP that has such high stakes and is so rapidly moving and has an available treatment now that's proven to be superior to the prior treatment. So it was a problem that although if it had happened 2 years earlier, the insured would have probably been off the hook. But at the time it happened, it was clear that the doctor was not adopting the standard of care. So this case settled for a $5 million total payout, with OMIC contributing $1 million on behalf of the insured. Case 3 involves a practice that has 2 ophthalmologists who treat RP. We'll have blue star doctor and red star doctor, depending on who saw the patient. So in December, first week of December, a child was born at 26 and a half weeks with a birth weight of 810 grams. First exam, January 19th, no ROP, either eye, follow-up 2 weeks. Next exam, February 3, noted to have zone 2, stage 2, both eyes, follow-up 2 weeks. 2 weeks later, zone 2, stage 2 and 3 in both eyes, follow-up in 2 weeks. And this is marked red. We'll discuss that a little bit later. In March, zone 2, stage 3, noted to have popcorn, stage 3 OU, no plus, follow-up 1 week. Zone 2, stage 3, now pre-plus, with some hemorrhage in the left eye, follow-up less than a week, 3 days. Zone 2, stage 3, no plus, follow-up another 3 days. Noted to have zone 2, stage 2 and 3 in each eye, follow-up in 2 weeks. 2 weeks later, different ophthalmologists here, switching ophthalmologists around that. Zone 2, stage 2, each eye with retinal hemorrhage. The baby was transferred at that time specifically for ROP, the note said, because of the new retinal hemorrhage. So the baby goes to another hospital where the ophthalmologist sees this child who now diagnoses zone 2, stage 3 plus with vitreous hemorrhage and performs laser. Unfortunately, the baby ends up 2200 in one eye and Tysical in the other eye. So some legal considerations for this case. Exam by the insured and the eventual treating physician done the same day were very, very different. Just going back here, you see the insured says zone 2, treater agrees. Insured says stage 2, but the treater says it's stage 3. No plus mentioned by the insured. Treating ophthalmologist said definite plus, and one says retinal hemorrhage, where the treating ophthalmologist says it's vitreous hemorrhage. So this very different interpretation of exam findings raises concern for exactly when type 1 disease actually first appeared. So let's say if all the exams by the 2 insured doctors are accurate, how did the follow-up look? Well, probably here on February the 17th, the child should have been seen in 1 week according to national guidelines. However, they kind of skated through this because there was still no plus at that 1 week exam. But here, again, there's another time when stage 3 appears. Follow-up was recommended to be 2 weeks again. So this is certainly a problem. This one is definitely too long of a follow-up time. And notice it's not just one physician, because both physician blue and physician red recommended 2 week follow-up when stage 3 was present in each eye. So that interval follow-up should not have been 2 weeks. However, OMIC had some expert physicians who said that the disease was likely still treatable at that point, and it wasn't a foregone conclusion then. Given all this, the lawyers felt that the overall economic value of the case could be as high as $8 million. So just again, a reminder from the AAP, APOS, AAO statement on ROP, people who should be followed up in less than a week. Any zone 1 disease, obviously, posterior zone 2 disease, and anything that's got stage 3 disease should be followed up less than 1 week. And, of course, ARP. So some things we can learn from this case. First, when ROP is present, you always have to make a note about the presence or absence of plus. Leaving it blank leads to a speculation that you didn't consider it, you didn't pay attention to it, or you didn't know. So even if there is no plus, it's a very pertinent negative. You have to write that. And of course, if it's not normal, you need to indicate whether it's plus or pre-plus. And so we had a number of exams here where the vessel status was not mentioned either way, which was not helpful to the insured. The next point is that we know it's often difficult. There's a spectrum from totally normal vessels to early pre-plus, and another spectrum from late pre-plus to early plus. It's often hard to make those distinctions clinically, and I'm sure everyone's aware of the research by Michael Chang that shows that there's pretty poor agreement among examiners when it comes to those intermediate stages. I mean, everyone could get normal and everyone could get bad plus, but the transition phases from normal to pre-plus and pre-plus to plus are often difficult, even for experienced RP examiners. What can you do to help us through this? More frequent exams can be helpful. Exams, if you have people in your practice that also do RP, do exams together, get a paired exam and an opinion there. Digital photography can also be helpful, and if you really don't know and there's nobody else, you can always ask another consultant to come in, or even if you're the baby to be transferred if you have no other option. But it's important to make particularly the distinction from pre-plus to plus, because that's the treatment consideration. And of course, we have to remember that you can still do everything exactly the way you're supposed to, and some eyes still do poorly in RP. We don't have 100% treatment for this. So the outcome of this case, it's settled for $500,000 per each physician in the group. And here's our last closed case from the last decade. November 29th, a baby born at almost 27 weeks with a birth weight very low, 375 grams, extraordinarily low birth weight. First exam, January 3, no ROP, tunica vasculosis lentis noted, follow-up in a week. Second exam, a week later, still no ROP. Another week later, still no ROP. 1 week after, still no ROP, but the vessels are noted to be growing a little bit more anterior into zone 2. Follow-up exam in 1 week, and here we see the first ROP, zone 2 stage 1 temporally, zone 2 stage 2 nasally in one eye, and zone 2 stage 3 temporally. And here's an exact quote from the chart with respect to the vessels: no frank dilation, increased tortuosity. Laser may be needed in the future. Follow-up 1 week. A week later, zone 2 stage 2 OU, vessels were noted as normal. Follow-up in 1 week. Zone 2 to 3, stage 2 temporally, zone 2 stage 1 nasally in each eye, no plus. Follow-up in 1 week. A week later, vessels out to zone 3 with stage 2, and the other eye zone 2 stage 1, again no plus. Follow-up in 2 weeks. 2 weeks, it says no change from prior exam, so we interpret that as meaning this. Follow-up in 2 weeks, March 21st, zone 3, stage 1 to 3 in each eye, no plus. Follow-up 2 weeks. Baby transferred for medical events to a different hospital, and there saw another ophthalmologist on April 3rd, where they find a 4A detachment in each eye, and laser surgery is performed. So some concerns here legally. The last exam is really not clear on how much stage 3 there was. We always know from the insurers stage 1 to 3 in zone 3 in each eye. So it doesn't really give us a sense of how much neovascularization there was, but it does say there was no plus. apart from this last visit, things look to be within the standard of care. Again, we have also the concern about, if there's a obvious plus here, why is the follow-up exam in 2 weeks? So everything looks pretty good up to this March 21st visit, but again, a long follow-up and unclear as to what the exam exactly showed then. And this case was settled before the long-term visual outcome of this patient was known. So some things we can learn from this case. First of all, again, be specific on how the vessels look. Normal, pre, plus, plus. Various descriptors yield concern as to what's really going on. If we go back and look at this case again, remember, midway through the case, it says no frank dilation. What does that mean? There's some unfrank dilation. Increased tortuosity. Well, is it increased to pre-plus? Is it increased in the spectrum of normal, or is it increased to plus? We really don't know the status of the vessels here because we're not clear on the normal, pre-plus, or plus configuration. Not a problem if you want to use these words, but you should say pre-plus disease, dilation more than normal but does not meet threshold for plus, or something like that. Another issue is, when there are multiple stages of disease in the same eye at the same time, it's important to indicate the extent of each clearly. So what is stage 1-3? Well, it could be 5 hours of stage 3 and 1 hour of stage 1, which of course is very different than 5 hours of stage 1 and a small area of popcorn. We just don't know. It's to everyone's advantage to provide as much detail as possible so that everyone understands the severity of the disease, and at that time as well as how quickly it's moving over the temporal profile of the entire case. And finally, remember this is a baby with a birth weight of 375 grams. This phenomenon of late worsening of disease in extremely low birth weight infants is well known. I'll show you some research from our institution in just a minute. And we have to remember that these very young, very small babies have to be followed longer. The disease lasts longer, takes longer to get better, but it also may take longer to reach the place where it's type 1 and needs to be treated. So this was a good outcome for the OMIC insured at $20,000 on their behalf. Nevertheless, still some things we can learn from this. So we talked about these really tiny kids. So what's the population? Well, here we have this group called P, and P stands for premature, and premature means the cutoff is 28 weeks. So if they're 28 weeks or older at birth, they go in the premature group. If they're less than 28 weeks gestation at birth, they go in the EP group, which is extremely premature. So the other axis is birth weight. So we have the low birth weight, which is under 1,500 grams, but then we have the extremely low birth weight, which is under 750 grams. So the premature low birth weight baby is a very different animal biologically than the extremely premature, extremely low birth weight baby. And in fact, I'll show you our research shows that all three of these are very different from one another. So this is a large cohort from the NICU at the University of Oklahoma, and here you see all the premature babies who are 28 weeks or more at birth. And you can see, here's the birth. The red is the range of the onset of disease, or at least first diagnosis of disease, and the blue is the range which the disease was fully regressed. So you see this time period here, but note in the extremely premature group, they get disease earlier and the disease regresses later. So in other words, the lifespan of the ROP is notably longer, if you put these all together, about 8 weeks or so longer in the extremely premature as opposed to the premature group. So we're going to see disease sooner, but we're going to have to follow them longer, both to regression as well as to treatment. And of course, as you would expect, the extremely premature get a lot worse disease than the premature. 9% of the time treatment was required in the premature group, but 29% of the time in the extremely premature group. So that's a significant threefold factor. Again, mostly bilateral here, but almost all bilateral in the EP group. And 91% of the EP group had to have both eyes treated as opposed to 50% of the premature group. So very different disease. Now, we can also stratify the extremely premature group into the low birth weight and the extremely low birth weight group. So again, here's the premature group as a whole, the 28-week or older at birth. And here's the extremely premature low birth weight as opposed to extremely premature very low, extremely low birth weight. And you can see that for the same amount of prematurity, if you decrease the birth weight, it has additional effect on the disease. So again, the disease lasts longer in extremely premature than premature, but it also lasts longer in extremely premature with a birth weight under 750 than extremely premature with a birth weight over 750. So again, a couple weeks. So you're here. We are the very small, very young babies. We're looking at regression, beyond 45 weeks, and sometimes we're even looking at treatment in this area as well too. The disease takes longer, and this is a really important point for us to understand because a lot of these babies are going to be seen as an outpatient, here in this group. So we're finding more and more people regressing later as an outpatient or meeting indication for treatment as an outpatient. So I wanted to end with a few words about informed consent. We're all aware of the components of informed consent that are necessary. I'll review those, but I also want to make sure that we understand, in addition to these things that we all know, the opportunity for questions is extremely important. ROP is a complex, complicated disease. It takes a while for parents to understand this. It often shows up later in the course of the neonatal history than a lot of other problems, and sometimes those problems are getting better and the parents are then just frustrated. Here's another new problem that they have to deal with. So a lot of education is necessary. Opportunity for them to ask questions and re-ask questions repeatedly is important. Certainly the informed consent process for treatment is made easier if they've looked at some material beforehand. The APOS video on RP I think is very good. I'm sure different hospitals have brochures on RP as well, the APOS website. These are all useful things for patients to get educated on as the disease is progressing. As a reminder, informed consent is an oral agreement. So that means there has to be a verbal conversation, and the surgeon must be part of the verbal conversation. The surgeon's role and responsibility is to tell to the patient about the diagnosis, what your treatment is, the risks, benefits, alternatives, and complications that could occur as part of that treatment, as well as the consequences of doing nothing. It's sometimes a long conversation and may need to be repeated a lot. But again, informed consent is a verbal conversation that has to comprise these components, and the physician must be part of it. The documentation, as a note in the medical record, is simply a documentation that this verbal conversation has occurred. And again, we should note that, and we should also consider using procedure-specific consent forms. Obviously, there's a general consent form that the hospital will have, but OMIC has provided specific consent forms that are quite detailed, both for laser treatment of ROP and anti-VEGF injections as well. These were just updated over the past year under Dr. Gold's supervision, and I think they're really well done. They're very detailed. They talk about systemic complications. They talk about immediate complications to the eye, and they talk about long-term prognosis and complications. So they're really very good. I recommend everyone take a look at these. And of course, you should keep the signed consent in the medical record and then give a patient a blank copy of what they've signed to be able to take home. Finally, obviously, sometimes there's a bad outcome despite the fact we do everything right, and sympathy and empathy become very important for the patient's family there. Sympathy, by definition, is understanding how somebody else feels, and it might be expressed by saying, no, this is a loss for you, or I'm so sorry this has happened. Empathy is, of course, when you try to identify directly with someone's feelings, and like the typical Bill Clinton statement, I feel your pain, or I hurt with you. This is empathy, and these are both important things that the family needs to get through this difficult time. Sometimes we're reluctant to have these conversations because they may not be comfortable, we may not be used to doing them, or there may be a concern that having these conversations place us at a higher risk of being sued. In fact, the converse is true. These expressions and conversations of sympathy and empathy, if anything, the research shows that there's a decrease in the chance of a lawsuit when we offer emotional support for families with bad outcomes. So it actually does protect us, and it helps the patient's family tremendously. So in summary, some of the things that we've learned from this talk are, first, we need to be very precise and careful when we discuss follow-up intervals for ROP evaluations. They should be date specific, or at least small ranges of acceptable dates rather than just a time interval. We also need to be specific when we describe what the retinal vessels look like. It's either plus, pre-plus, or normal. If you want to add flowery extra adjectives, it's fine, but you've got to have whether it's normal, pre-plus, or plus in there when there's ROP. And also the extent of ROP stages. Stage 1-3 is not really as helpful as it can or should be in conveying what the severity of this disease is. So tell us how many clock hours of each stage, show us where it is, etc. There are a lot of descriptive factors in ROP where there are endpoints that are hard for us to be absolutely certain on, and it includes when pre-plus goes away and turns into plus. What's that exact moment? Where's the exact place between zone 1 and zone 2, or between zone 2 and zone 3? Obviously, our clinical expertise and practice gets us good at this, but when we're not sure, some techniques to help us are more frequent exams so we can see changes more rapidly, paired exams with somebody else, and of course the use of digital photography, whether you're looking at yourself and comparing it or whether you show it to a colleague for their opinion. And also, extremely premature, very low birth weight babies have a longer temporal profile of disease. Whether they get better or whether they need treatment, it starts earlier, and the time to get to either of these endpoints of either treatment or spontaneous regression is longer. So we have to be prepared to follow these patients longer, and we have to be prepared for the fact that often the endpoints are going to be met as an outpatient more frequently than they were in the past. And finally, when there are bad outcomes, we have to be empathetic and sympathetic with the patient, and before any treatment is performed, we really must get true consent, informed consent from the family through a verbal conversation between us and the parent or parents. So I'd like to thank Dr. Orge and the organizers of this meeting for the privilege of presenting to you, and I'd like to thank OMIC for their assistance in providing me some data, and hope that you all enjoy the meeting. Thank you.